Well, hello everyone, and welcome to another session of our 2020 Functional Aging Summit going online. Really appreciate you guys being here. Really excited about this session because I'm excited to learn about this myself. Dr. Bruce Crawford is joining us to talk basically about his method that he's developed, I'm sure over quite a number of years of practice of doing basically Pilates applied for pelvic floor therapy. And you've trained like over 5,000 medical professionals, is that right? Or medical and fitness professionals?
Yeah, mostly fitness professionals, well, probably evenly split between Pilates instructors and physical therapists and
Mhm.
personal trainers.
Well, yeah, you've done a lot of work in this area then, and you're a board certified urogynecologist. So are you still practicing?
Yeah, I still am.
Excellent,
But I
good.
have changed it radically. I'll talk about that
Okay, good, good. Well, really
early
excited
on
to
in the
have you
talk.
here and looking forward to what you're going to share with us. Just for everybody, really quickly, we are recording the session as well. And also questions, if you want to put them in the chat box, we will try to kind of monitor that and integrate those. But also we will try to have some time at the end for some question and answer as well. So really excited. It is all you, Dr. Crawford.
Thank you so much. Thank you. It's really an honor to be here. And this is a new experience for me. I do want to right away introduce Heather. Heather, if you could just share your screen or share your video rather, so I can see you. I find that comforting to look at you.
Oh, okay. I'll keep it on.
Heather's one of our master trainers and probably the best movement instructor I've ever met or worked with. It's a real honor. And so thanks, Heather, for being here as well. So yeah, this is a new format for us. Not just in terms of doing this as a live webinar, but the Functional Aging Institute is a new program that we're fortunate enough to have been introduced to. And, I kind of tuned in a little bit early and caught the last half of JR's talk. And man, that guy has tons of energy. And so I'm going to try and keep my energy up for you guys too. But everything he's talking about in terms of creating a medical fitness facility and restoring people's lives and bodies and health without medication or surgery, that's what we do. You know what I mean? But because I guess I'm not a very good networker, I don't know the other people that are out there doing it. It sounded like he was about 100 miles ahead of us on the road to doing this thing. But I enjoy what I'm doing. And this today, what we have in terms of day-to-day practice is so different than it was just 7 months ago. 7 months ago, I still had a traditional urogynecology practice here in Northern Nevada. And I had stopped operating. I haven't operated for a couple of years now because, I was starting to see the light. And I still those, seeing 20, 30 patients a day and dealing with insurance companies and not having enough time to really spend with patients. And so because of a number of events, an opportunity arose for me to not do that anymore. I closed that practice and I opened up Vessi Lab and its compatible healthcare partner called Vessi Health. And it's a concierge medical practice. It's a state-of-the-art Pilates studio. We offer yoga and Tai Chi and massage and nutrition programs. And we have a really sophisticated pelvic floor rehab program, which is the main focus of the talk today. And it really came about from some experiences I had 10 years ago. I was doing all this volunteer surgical work in West Africa, in Niger specifically, which is like just the poorest country. And we'd go to Niger and fix something called an obstetrical fistula. Maybe some of you have heard of that. There's about 2.5 million women living in sub-Saharan Africa with this childbirth related injury that occurs because there's no access to emergency obstetrical care in these just wicked poor places. And what happens is when labor obstructs, as it sometimes does, C-section wasn't available, and the baby's head would put so much pressure between the bladder and the back of the pubic symphysis that it would cause that portion of the bladder to die and to slough. And unfortunately, in those situations, the baby always dies. A third of the time, the mom dies too. But of the 2/3 of moms that don't die, they wind up about 6 days after the baby does pass with a huge hole between the bladder and the vagina, making them completely incontinent of every drop of urine their body produces. And so living as a woman in sub-Saharan Africa does not afford you tremendous civil liberties to begin with. And if you become completely incontinent, you are in real trouble. And so we'd go and we'd fix 200 or 300 fistulas a year. And pretty successfully, pretty reliably successfully, we'd do this, restore the anatomy. We could, in 8 out of 10 cases, close the hole. But many, many, many of these patients, even though the anatomy had been restored, structure was restored, remained incontinent. And I'm kind of a slow learner, I guess, because after 4 or 5 or 6 visits to Africa, I started to say, well, this really isn't compatible with everything I've learned as a physician and surgeon about how to treat bladder control problems. As I was trained, structure and function were intimately related. And if you, as a surgeon, restore structure, you should restore function. But that's not what we were seeing. We were seeing persistent functional deficit, although the anatomy was, in quotation marks, normal again. And I realized after a period of time, measured in years, that bladder control actually is a neuromuscular phenomenon. It is not a structural phenomenon. We used to always think, oh, this is related to urethral support or bladder support. And although that may have some influence, the main factor that determines somebody's ability to control their bladder relates to the neuromuscular function of the pelvic floor and the components of the pelvic floor that lend themselves to the urethral sphincter, the smooth muscle and skeletal muscle component of the urethra that keeps the pressure in the urethra greater than the pressure in the bladder. And if you have that situation, the urine stays in the bladder until you can find a socially appropriate time to empty the bladder. And so I came back home thinking, we should do something better for our patients. We should find an intelligent, sophisticated, effective neuromuscular solution for these patients. And everybody, if they were going down that path at all, when I say everybody, I mean my colleagues treating patients with these problems, they'd say, yeah, we tell them to go home and do Kegel exercises. And yet, at this point, I had done 5,000 slings for bladder control problems, and nobody was doing Kegel exercises. And so we needed something more practicable and more effective and more quickly effective to avoid attrition from programs that were oriented towards restoring bladder control without surgery. Now, we have had physical therapy programs, sometimes called pelvic floor therapy, for bladder control that involved using biofeedback to show people on a screen, usually while they sat in a chair, what their pelvic floor muscles were doing. And you can ask them to contract them quickly, you can ask them to contract them slowly, you can ask them to, but patients, the attrition rates from these programs are like 40, 50, 60%. Patients were dropping out, weren't following through. And those that were compliant, it works, which is cool. And good for those that were able to maintain compliance, but we wanted something more practicable. And it became apparent to me that the pelvic floor muscles were an element of the core muscular system and were muscles of movement. And muscles of movement are best trained using movement. And so hold on just 1 second. Sorry about that. And so anyway, so we wanted to devise a method of movement that was more practicable and so I started talking to people I could collaborate with about how we might do that. And, few of the people I reached out to even knew what the pelvic floor was. Pilates instructors seemed to understand what the pelvic floor was. And we finally wrote a protocol that allowed us to study 120 personal training, yoga, and mat Pilates movements using a system of video EMG synchronization, which I'll explain in greater detail, to determine which movements provide passive engagement of the pelvic floor. That is to say, that make the pelvic floor muscles contract, whether you can do a Kegel exercise or not. And it was quite laborious to collect all this data and to analyze all the data, but ultimately we were able to find a series of 10 movements that we felt were safe for people to do and that were effective at providing passive engagement of the pelvic floor. And originally it was just going to be for my patients. And then someone said, well, you should make a video. Maybe other people want to do it. And so I kind of go overboard on things like this. And I made a video and distributed thousands of them, thinking now I'm done. Everybody's going to do this perfectly. And that, of course, was wrong. Nobody did it perfectly. And so I was lamenting that. And it was suggested, well, what you need are instructors. You need to train some instructors, them plus the video, then everybody will do it perfectly. And so now we've trained 5,000 instructors all over the world. We have 1,000 in Japan. And in fact, this month they're doing the first online Pilates certification. The method's called Pilates, P-F-I-L-A-T-E-S. And they're doing their first online certification with 100 participants in like a week or two. I know, can you believe that? And so it's really grown tremendously over the last 10 years. And since that time, we've turned the methodology we used in the original experiments of monitoring multi-channel EMG synchronized to a video image. We've turned that into a clinical instrument and now can customize people's programs. We just use that every single day here at Vessi Lab and Vessi Health. I'm going to try and share my screen so that we can look at some slides, if I can. It's saying that the host has disabled my screen, but maybe if I just do this, you guys can, I trust you guys can see this now. I don't know. Heather, were you able to see the screen when I just had it up, the slides? I'm gonna try one more time. Let's see. So anyway, if the host is still with us, it says host disabled participant screen sharing. So am I going to be able to show some slides here? Or?
Yeah, if you just hit the green share screen button, it should pop up a window to allow you to choose the window you want to show.
Oh, okay, I'll try it again. Still, every time I hit the green button, it says host disabled participant screen sharing.
Well, here we go. Try it now.
I will try it again. Yay, that's much better.
There we go.
Thank you.
You are welcome.
And so let's see, let's share some slides and do a slideshow. Cool. And so now it's like a whole thing, and it's because I opened an email 12 years ago and wound up in West Africa. Now my whole career has changed. I don't operate anymore. I don't have a traditional urogynecology practice anymore. And I am just absolutely loving what we're doing now. And so integrating the fitness aspect of what I've been working on for the last 12 years with a concierge medical practice has been awesome. I have time to spend with my patients. I'm only taking 100 patients, and they have access to a really wonderful array of fitness and nutrition programs in addition to house calls from us and telehealth and a whole bunch of other stuff. And so one of the things that we've realized, I don't want this just to be a big infomercial for Vessi Lab and systems and the Pilates program, although I do want you all to come and take the certification we're doing July 25th. Write that on your calendar, Heather, if I haven't shared that date with you yet. We're going to do a online 8-hour certification, and it's should be spectacular and convenient. I have to commend all of you for furthering your education despite the difficult times that we're living in right now. Despite that adversity, you guys are thinking, how can I improve myself? How can I make myself more useful and valuable to other people? And how can I better my career? And so I want to give you something practical today in and of itself, aside from any future endeavors we may embark upon together, and share with you what we've learned, and me being sort of the ultimate pragmatist, what we've learned that's actually useful to apply in your practices tomorrow. I assume we have a bunch of fitness professionals and physical therapists and nurses, hopefully some doctors too, and this is equally relevant. You know, it's incredible how broad the interest in the pelvic floor is. Since I've opened Vessi Lab, we get referrals from urologists, certainly, and OBGYNs, and those would be the sources of referrals I'd expect, but we're getting referrals from radiation oncologists that are treating rectal cancers and anal cancers and colon cancers. We're getting referrals from gastroenterologists for patients with bowel control problems. We're getting referrals from a really broad array of medical specialties, because it's just every specialty has a pelvic floor problem within it. You know, whether it's bladder control, prolapse, bowel control, sexual dysfunction, pain complaints. The pelvic floor is making its presence known. And despite that, this remains what I call the last fitness issue. This is an issue, this is a piece of anatomy that most people don't even know they have. Like, how many parts of your body are you unaware of, right? We'd like to think we know all the parts of our body, but a lot of people don't even know that they have a pelvic floor, and if they are aware of it, they probably don't have a keen understanding of its relevance and how it works with the rest of the body, and specifically with the rest of the core. So we can think of the pelvic floor as the floor of the core, if you will. And the floor of the core is naturally related to muscles of movement. And this slide reminds me to tell you in broad strokes how that works, right? So obviously we're looking at a hemipelvis from the lateral view, right? So we're looking at the side of a half a pelvis. And we see up top that yellow portion is the ilium, and then the pink portion is the pubic bone, and then the ischium is the final kind of purpley brownish portion. And it has that kind of rounded area down here that the Pilates instructors have a good name for. They call this the sits bone. We call, urogynecologists say that's the ischial tuberosity. But the sits bone is, right, it's kind of what you sit on. And so these three bones fuse at the acetabulum of the hip, and they provide a point of insertion for three of the most important co-recruiters of the pelvic floor. What's a co-recruiter? A co-recruiter is a muscle that is wired to cooperate and coordinate with pelvic floor activity. And these are motor pathways that get established when a small child first pulls itself up and begins to walk. And so you have the point of origin for the gluteal muscles of the lower extremity adductors and the transversus abdominis along the iliac crest here, all surrounding what's on the other side of this image, which is, of course, the pelvic floor muscles, right? And so what that does, in essence, is create a column of rigidity that extends from the sternum, where the transversus abdominis originates from, down to the knees, where the lower extremity adductors insert, that keep you from flopping over when you are upright. And so you don't have to think about it, fortunately, right? These motor pathways are automatic, if you will, or some people would say reflexive. You can leverage this understanding of how our neuromuscular system works into creating a more intelligent, more effective program for pelvic floor performance training. And so again, the idea of isolating the pelvic floor is really arcane and lacks consideration. And historically, we have a kind of bullied patients into doing isolated pelvic floor contractions by monitoring with biofeedback what these other muscle groups are doing and say, nope, 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 you're not isolating the pelvic floor. You're using your abdominal muscles, or you're using the glutes, or whatever. You got to isolate the pelvic floor. And it's very, very, very difficult to isolate the pelvic floor, even for trained athletes and fitness professionals. And the reason it's difficult to isolate the pelvic floor is, wait for it, it's not natural to isolate the pelvic floor. It's unnatural for the pelvic floor to work in isolation. And so an isolated Kegel exercise just doesn't make functional sense. The pelvic floor muscles are muscles of movement. And as an element of the core, Joseph Pilates teaches us that every movement begins with the core, right? First the core, then do the movement. And so we can understand that by doing the kinds of experiments that we did early on, and then we've been refining it for the last 10 years. When we started out, teaching the Pilates method, we did not know what we were doing. We still don't know what we're doing, but we know a little more than we did 10 years ago. We taught these 10 exercises, in the context of a traditional fitness paradigm. And now we realize it's better to customize the program, and of those 10 movements, figure out for each individual which one or two or maybe 3 movements are going to be their best movements in terms of creating the greatest degree of co-contraction of the pelvic floor, and then giving them a custom program. And so Heather will go over in some more detail, what are the mechanics of doing a Pilates movement? How is it different than a traditional lunge or a traditional bridge or a traditional hover or a traditional squat? And how we use principles of overflow to really augment the number of motor units in the pelvic floor that are firing with each contraction by bringing someone up to a point of peak passive engagement, having them hold the movement there, and then add a series of forceful, voluntary, fast pelvic floor contractions with something we call percussive breathing to really improve the motor unit recruitment. And with that comes improved efficacy and a quicker timeline to recovery, which reduces attrition and helps people not give up and go have an operation. That's kind of like everything I've figured out in the last 12 years in a nutshell. So these little muscles that are not part of the pelvic floor, these are the big, strong pelvic floor muscles. The one that we're most interested in is the pubococcygeus. Some people call it puborectalis, that kind of circles underneath the upper part of the anal canal, lower part of the rectum, and inserts on either side of the pubic bone here and here. But these little muscles, like the superficial transverse peronei, the bulbospongiosus muscle, and the external anal sphincter, have the same nerve supply, right, as the pelvic floor muscles. And so they work in coordination. And we'll talk about why that matters when I go into the description of how prolapse, pelvic organ prolapse, is a fitness problem. And so I think it's easier to understand how stress incontinence might be a fitness issue, and even overactive bladder perhaps, but for people to understand that the true origin of prolapse, for which hundreds of thousands of women have surgery every year, is a fitness issue. It's a radical idea, and most actively practicing urogynecologists, reconstructive pelvic surgeons like myself don't understand that. And it's an inconvenient truth, if you will, because it challenges their idea about what first-line therapy should be for these problems. It's extraordinary that 6 million times a year in the United States, a woman gives birth, and seldom does anybody have a conversation about rehabilitation of the pelvic floor. Now, consider every patient in the United States that has an ACL repair. Do you think they get their quadricep rehab? Of course they do. In fact, if that wasn't insisted upon, the doc would be considered negligent. You have to rehab that quad because there's predictable neuromuscular damage. Same thing with a rotator cuff repair. You go to rehab. But 6 million times a year, a woman puts somebody's head in her vagina, and the pelvic floor doesn't get rehabilitated. And it's just complete oversight, and I think gender bias that dictates this. There's predictable neuromuscular injury to the pelvic floor with vaginal birth, and there's a lot that can be done to optimize recovery. Within that first 6-month window after childbirth, but especially during the first 6 weeks after vaginal childbirth. And so I really consider those patients, the near postpartum patients, to be sort of the holy grail of what we want to provide for with this method. And ideally, educating them about the availability of this method before they give birth, so that when the baby comes, they don't have to start from scratch. When a new mom brings her first baby home, I can assure you she's not thinking about her pelvic floor, right? She's nervous about having a baby. Just learning how to give the baby a bath is a major challenge. When we brought our daughter home, I was practicing a real traditional OB/GYN practice in those days, delivering babies all the time. But when we brought our daughter home, I gave her a bath for the first time. It took me 45 minutes, and I'd have a drink afterwards. It was very stressful for me. And so we need the fitness advocates that to say, I know you're not thinking about this. We've discussed this ahead of time. I got your back. We've defined your program. These are your movements, and we need you to get started as soon as practically possible. And some might say, well, don't women have to rest after having a baby? Isn't it unsafe for them to be doing any sort of physical exercise? Nonsense. Where does that come from? For some reason, healthcare providers have this almost irresistible urge to tell women to get in bed, especially during pregnancy, but afterwards too. It just makes them feel better. There's no clear evidence that bed rest delays preterm labor and delivery, but we still tell women with preterm contractions to get in bed. We know it causes bone demineralization and depression and increases their risk for deep vein thrombosis and pulmonary embolism, but we still tell them to do it because we can't think clearly and we can't think in a data-centric fashion. Likewise, the time to begin a rehabilitation program after a neuromuscular injury is : fill in the blank. You guys already know the answer to that, right? It's as soon as practically possible. Why? Because within 96 hours of a neuromuscular injury, you're already developing skeletal muscle atrophy. And that's what we want to avoid. And it begins very quickly. So the time to begin a program of neuromuscular recovery is as soon as practically possible, with a single but very important caveat that if a woman during childbirth sustains a 3rd degree or 4th degree perineal laceration, which means that there's a tear or an extension of an episiotomy into or through the external anal sphincter, which affects about 1% of delivery of women giving birth vaginally, then you have to wait. You got to wait 6 weeks. Because when that sphincter gets put back together, the repair is tenuous in the best of hands, and you need that anal sphincter to be in continuity to maintain bowel control. And so it's unfortunate that for that 1% of women that have delivered vaginally, they can't embark upon a program of pelvic floor rehabilitation. But right now, pretty much nobody is. And so we can bring something very useful and essentially no risk to the 99%. And we should be doing this. And it's really an opportunity to become a champion within your area, because these problems are just massive in terms of their impact on quality of life. Overactive bladder, which is a form of urinary incontinence, is second only to major depression in terms of its impact on quality of life. And loss of bladder and bowel control is the #1 factor associated with the decision to put an elderly woman in a nursing home. That is astonishing that we don't talk about this. When I tell patients this, they just look at me with their mouth gaping open, like I had no idea. And the fact is that families can put up with a great deal of cognitive decline before they decide to put grandma in a nursing home. But if she loses control of her bowel and bladder, it crosses a cultural threshold. It's the same thing we saw with the fistula patients in Niger. If you are incontinent to that degree, the family is really challenged to put up with it. There's something so repelling about the smell of stale urine that these patients, these people, will be ostracized and sacrifice their financial security, their physical security, their relationships, and we see the same kind of cascade of negative consequences in the United States among the elderly, as we saw in West Africa among the younger fistula patients. So anyway, what we're looking at here is a lateral view of the female pelvis, right? And so here's the pupil. Let's take a little tour here. Here's a pubic bone right here, and then this is the urethra and the bladder sitting right here behind the pubic bone, and this is the uterus, and this is the last part of the sigmoid colon and the rectum, and here's the anal canal, right? This is the perineal body, super important structure that exists between the anal canal and the vagina, which is right here. So if we follow this white line, which represents the anterior wall of the vagina, the top wall of the vagina, it runs under the urethra, under the bladder, and it represents a denser connective tissue that then surrounds the uterine cervix. And then that same connective tissue comes down the back wall of the vagina and integrates into the structure of the perineal body. And so it's kind of one weird shaped piece of connective tissue that doctors call fascia. And it's not super duper dense like the abdominal aponeurotic fascia that you fix if someone has like a umbilical hernia or a ventral hernia. It's not quite that collagen dense. It has more smooth muscle, but I think the gynecologists were jealous of the general surgeons and they wanted some fascia too. So they call this pubovesical cervical fascia. And it is structurally important because it supports the position of the urethra and the bladder and the uterus and the rectum in the upright person, in the upright woman. And if that structure is damaged, then a problem called pelvic organ prolapse occurs. But the thing is, real people aren't like this slide. Real people are 3-dimensional. This slide's 2-dimensional, right? And so I need you to do a little mental exercise right now. We can do it together here. And imagine we're going to surgically remove this piece of connective tissue from the top of the vagina, where the uterine cervix is residing, all the way down to the opening of the urethra. Just this one portion of the pelvic fascia. We're just gonna surgically remove this, take it out, and we're gonna hold it in our hand and look at it, okay? So now that you've accomplished this, I want you to tell me what a shape that piece of connective tissue is. It's not a line, right? It has 3-dimensionality to it. What is the shape of that piece of tissue? And I'll give you a hint. That tissue extends from this structure called the ischial spine on the right hemipelvis to this structure, the ischial spine, on the left hemipelvis, high within the pelvis, right? And so way up here in the pelvis, this structure is extending from ischial spine to ischial spine. And I'll give you another clue that'll help you make a mental picture of the shape of this piece of fascia. Down low in the pelvis, right under the pubic bone, this structure extends from the right side of the pubic bone to the left side of the pubic bone, right? It is a shorter distance than the upper part spans, but nonetheless, And finally, the same connective tissue, obviously it's all in continuity, you can probably begin to figure out has sort of the shape of a triangle with the tip cut off, and that's a shape we call a trapezoid. We call that a trapezoid. And so there's a trapezoid of connective tissue underneath the bladder that is attached to the bony pelvis, beginning at the level of the ischial spine, all along the length of the connective tissue and all the way to the pubic bone. And so it's a trapezoid of tissue that forms a hammock, if you will, underneath the urethra and the bladder. Now, what about this piece of connective tissue over the rectum? What if we did a similar operation and we just removed this piece of tissue, held it in our hand, and tried to figure out what three-dimensional shape it had? Well, what we would see is that it has the same shape as a segment under the bladder. It goes from ischial spine, and down low, it traverses the span of the perineal body, right, from the right to the left. So it's a triangle with the tip cut off. It's a second trapezoid of connective tissue supporting the back wall of the vagina, which holds the rectum in place. And so you have these two trapezoids kind of laying on top of each other. Now, what happens every time you cough, sneeze, laugh, run, jump, do anything of significant strain that increases intra-abdominal pressure, what happens is your body is pre-programmed, as we were talking about a few minutes ago, because of the co-recruiters, the co-contractors. It's pre-programmed to reflexively contract the pelvic floor muscles, okay? So the pelvic floor muscles that are running from one pubic bone beside the urethra, vagina, and rectum, behind the rectum and up the other side, right? Creating, in essence, a second kind of sling around all of these structures. They shorten when there's a reflexive contraction. They shorten when there's a reflexive contraction, and they pull this structure and this structure towards the pubic bone, right? So they would shorten this length. You can see in the normal standing female, the upper 2/3 of the vagina are kind of horizontal, and the lower 1/3 of the vagina is kind of vertical. But when she coughs, what happens? Pretend this is a video now, and she's going to give a big cough, and we're going to get a reflex contraction of the pubococcygeus puborectalis, and it's going to pull these structures toward the pubic bone. What's going to happen to the position of the bladder and the uterus? What's going to happen is the upper 2/3 of the vagina is going to further flatten because these muscles are pulling the lower 1/3 of the vagina into a more closed state. And when you flatten the upper 2/3 of the vagina, the force of the cough, the abdominal pressure that's being developed, comes to bear on the muscle, not on the connective tissue. So this is the pelvic floor's way of protecting that connective tissue from the force generated by effort. That's the functional purpose of the pelvic floor in the upright animal, is to protect this connective tissue. If these muscles don't work, if they've been damaged, they're atrophic, they're weak, they've never been recovered after an injury such as after vaginal childbirth, what happens is the vagina remains relatively vertical during a cough, and the force of that cough is directed out the opening of the vagina, and the anterior trapezoid begins to detach at the ischial spine on the right and left, and it pushes the bladder and the uterus down towards the opening of the vagina. And if it gets to the opening of the vagina, the patient shows up in your office and says something like, there's a problem down there, like there's a problem in Australia or something, right? We don't even want to use the words to describe this anatomy, right? As a ridiculous barrier to care that hardly any other medical specialty has to deal with, right? And patients will delay care because it's embarrassing, they want to talk about it, it's just part of being a mom, you know, the misinformation goes on and on and on. But this is why pelvic floor dysfunction is a fitness issue. This is why if you don't do something about pelvic floor damage when it occurs and do it as close to the time of injury as possible, that you are at risk for developing prolapse of the pelvic organs. And this is seldom understood. And so, you know, if you do pelvic reconstructive surgery and you fix a prolapsed bladder or prolapsed uterus or something called a rectocele, and you don't rehabilitate the pelvic floor, that you have missed the point. And you have to make that decision while understanding that 30 to 50% of pelvic reconstructive surgery procedures fail. And a third of women have a second pelvic reconstructive surgery for prolapse. I think those numbers are begging us to say, why is this happening? Why is it failing so much? And what happened in the 1990s is medical device industry went to doctors and they said, you know, we noticed that your surgeries are all failing, and what can we do to help you with this? And the docs that really didn't have this kind of insight into the true mechanism of prolapse said, well, the problem is the patient's tissues are weak. This is such a classic example of blaming the patient for physicians' own failures. And the medical device company said, well, so what you need is stronger tissue. And the surgeon said, yeah, we need stronger tissue. And they invented the permanent synthetic mesh that has caused no end of trouble ever since to be used, because yeah, it's strong. You could lift up a car with it, right? But you know, there were pain problems and erosions and infections and functional consequences for many patients that, you know, resulted in the, you know, lawyers putting advertisements on television so that they could sue the medical device industry, which had already made, you know, 10 times more money than they'd ever pay out in legal settlements. And so it was a big success story, right? That's the reality of it, right? That's the reality of why pelvic floor repairs fail. Hopefully, in your mind, this is something like what you were visualizing, this trapezoid of connective tissue that needs to be repaired, or needs to be protected. And the way to do that is by making the pelvic floor work properly. You guys now know something that not 1 in 100 doctors know. And what really matters is if you take this information as inspiration to do something about it, to gain the knowledge about how to apply a method of pelvic floor rehab so that this doesn't happen. This patient showed up in my office. She's had a hysterectomy already. The cervix used to be here, but her vagina is completely turned inside out. And I'd see about 1 case a month this severe. It's as if you reached inside a sock, grabbed a toe, and pulled it out through the opening. She's had complete detachment of the anterior trapezoid, which is under this portion of the vagina that's exposed, complete detachment of the posterior trapezoid, and complete eversion, if you will, of the vagina. And all the Pilates in the world isn't going to fix this, as you might glean from the fact that this picture was taken to in the operating room. I had to fix this. And this is a urinary catheter going in the urethra. But you know what? How did it get this severe? Why did the patient wait to come in for so long? These are the barriers to care that we need to break down by talking about these problems in an unabashed way. We have to have the courage to use the language and ask the questions, because these problems are affecting people's lives, and fixing this is not a small operation. This is a big deal. And not to mention, as we started out this little talk by saying, replacing structure, replacing the anatomy does not necessarily imply restored function. After this kind of radical pelvic reconstructive surgery, what do you think the chances are that she is without sexual complaint or has perfect bladder control, right? Many of these patients remain functionally impaired despite the anatomy being normal, right? So that makes a pretty good argument for primary prevention, which is really what we should be doing, and what we have the means to do. But the incentive structure of the healthcare industry discourages us from doing it. And that's wrong. You can get upset about it and mope about it, or you can do something about it. You can become an educator, and you can provide intelligent, sophisticated solutions like the Vesey-Pilates method, and they help people not get here. Certainly it can't get worse than this, right? Wrong, it gets worse than this. This patient was brought into my office, sorry about these peek and shriek slides, but I'm trying to make an impression. Same kind of vaginal prolapse, but she's also prolapsing her sigmoid through her anal canal. And that was only discovered after her daughter looked under her nightgown. That took years to evolve. That took years to evolve, and yet nobody brought it to a physician's attention. And so you think that has a negative impact on someone's life? You'd say, surely that's rare. It's just not that rare, unfortunately. I was seeing this frequently in the office. And so we know it matters. We know it matters. And so, you know, this is a slide taken at the time of a laparoscopic procedure I did for a cystocele, which is when the bladder is prolapsing ahead of everything else. And what we've done here is we've made an incision in the peritoneum along the top wall of the abdominal cavity. So what you're looking with a telescope from the belly button down into the pelvis, right? So imagine the room you're sitting in is someone's abdominal cavity. And so looking straight ahead, you'd be looking down towards their pelvis, right? And so if you made an incision along the ceiling of the room you're in down towards the pelvis, and then you took the edge of that incision and you pulled it down, you'd bring the bladder down with it. And then you could look on top of the bladder, right? So this is the top of the bladder. And you can see that we've placed sutures here and here and here and here and here and here and here to replace that anterior trapezoidal laterally from where it detached, starting here at the ischial spine and extending all the way down to the pubic symphysis, which is here. And we did it on both sides. Well, this repair is a pain in the ass to do. And guess it's a little sore after too. And wouldn't it be better not to have to do this? And if you go through all of this to repair a cystocele and you don't rehabilitate the pelvic floor, what are you doing? What are you doing? You have taken a decongestant for a stuffy nose and the cold rages on. Guess what? You shouldn't be surprised if in a few hours your stuffy nose comes back again. So the pelvic floor muscles, the pubococcygeus, the iliococcygeus, and the coccygeus should be better understood. We're mainly concerned with this first, thickest, bulkiest component of the pelvic floor called the pubococcygeus. It extends from the pubic bone here, down beside the urethra, the vagina, the rectum, up the other side, making this sling. And we know it contracts reflexively with movement that increases intra-abdominal pressure. And that's the premise on which the Pilates method is based. Now, these other muscles, like the gluteal muscles, right, that are arising from the iliac fossa and the lower extremity adductors, there's a whole bunch of them, but we can consider them as a group for the purpose of this talk, and the transversus abdominis. We started out by saying naturally are integrated with the firing pattern of the pelvic floor muscles, right? And it creates this column of rigidity from the sternum all the way down to the knees with the pelvic floor right at the center. And so why is it difficult to isolate the pelvic floor? I said it already, because it's not natural to isolate the pelvic floor. These muscles work as a family, and the family likes to work together. And we should let them work together, and we should be smart about devising a program that allows them to work together and then customizing that program for each individual's needs. And so with respect again to vaginal childbirth, there's just no good way to get a baby out, right? You've got to get this out of this. And that is not surprisingly going to cause some neuromuscular injury to the pelvic floor. Cesarean section isn't the answer for all patients. What we need to do is say, we know this is going to cause an injury. We've got your rehab program already in place. Is anyone in your community doing that? Could you partner with the childbirth educators in your community and say, look, I've learned a lot. In fact, I went and got certified in this method and continue to work closely with Dr. Crawford and the team at Bessie Lab. We'd like to implement a program for every mom, so at least she has an opportunity to partake in this. Not everyone will. It still involves exercise, right? And some people are repelled by that alone. But we should at least have an opportunity to do something about it and avoid the consequences of not doing something about it that result in medication and surgery and things that we don't want. But right, this is going to continue to happen, fortunately, right? It's a wonderful thing, but it's not without consequence, and we should be smart about it. Women deserve it. This is a good cartoon I made that shows the normal position of the bladder and the vagina and the rectum and the pelvic floor muscles here, right, in their non-vaginal delivery state. And then on this side, there's a head in the vagina. And you can see it's displacing the bladder here. The vagina is displaced all the way like this, and that anterior trapezoid is being torn away from its lateral attachment here, right? And the posterior trapezoid's being torn away from the perineal body here, which can result in a different kind of prolapse called a rectocele, but it's the same idea. It's a bulge that is uncomfortable and causes functional problems. And the pelvic floor muscles that were here are now all stretched as the baby's head comes through the vaginal canal. The pudendal nerve, which is bringing the nerve supply from S2, 3, and 4 to the pelvic floor, is being compressed here. And so there's stretch injury to the pudendal nerve, there's compression injury to the pudendal nerve, and that denervation is what results in atrophy. And so the best way to rehabilitate muscle is as soon as practically possible after the injury, because we know pelvic floor exercise or any therapeutic exercise actually increases the production of nerve growth factor, which helps that new peripheral nerve grow, right, from the spinal cord back down to the target muscle and reinnervate the muscle, not as well as it was before, but optimally so. And so therapeutic exercise is important, and you got to do it quick before you lose the muscle tissue. We know at the time of vaginal birth, the pudendal nerve gets stretched 13 to 35% of its resting length, and we know predictable axon damage, denervation, occurs after peripheral nerve is stretched beyond 15% longer than its resting length. And so it's predictable that these injuries occur. Now, one thing VESI's allowed us to do, again, VESI is this means by which we can, let's see here. Heather, can you see this? Can you see a VESI clip on your screen?
No, I still see your slide deck.
Well, I want you to see this.
Go back down to your share screen button. You can.
Oh, yeah, okay.
Between windows.
All right, he's teachable. Let's see here. Look at this. This is a VESI clip. What does that mean? VESI stands for Video EMG Synchronization. I invented it. I just got the patent in April, actually. That was hard to do. Anybody ever get a patent? It took years of arguing. And finally, I think that they just wanted to get rid of me, so they gave it to me. That's being a nuisance. And so it's a way of analyzing an individual's response to an array of movements and then just picking the movements that provide the best functional result. So they can forget about ones that aren't doing that much for them and just do the ones that are going to give them the results quickly. And that matters because if you don't make people better quickly with exercise, they quit, give up, and go have an operation or take a pill. The best medicines there are for overactive bladder take 6 to 12 weeks to work. And results we're seeing using methods selected, movements selected in this fashion are providing a 50% improvement in 28 days of training. That's the only statistic I'd ask you to remember, is that when the Pilates method is applied in a custom way, the clients can expect a 50% improvement in bladder symptoms in 28 days of training. And so this is how it works. Each movement you analyze is analyzed in the same fashion using maybe a 1 minute, 30-second to 1 minute VESI clip. A VESI clip is the patient doing the movement while you simultaneously record 4 channels of EMG. Out of convention, the top channel is always the pelvic floor. The second channel is always the gluteal muscles placed on the left side. The third channel is always the abdominal muscles, really trying to target the transversus abdominis. And then the final channel is the lower extremity adductors. So the 3 main co-contractors in the pelvic floor. During the VESI clip, we start recording, and the beginning of the recording is over here on the far left-hand side. And we say, just stay relaxed and do your best Kegel exercise. Do your best isolated Kegel exercise. And then when they do that, you should see the pelvic floor channel react. And so this person can do a pelvic floor contraction, and here it is. You can see my cursor, can't you, Heather? I'm trying to circle the Kegel. This is what she's able to achieve with her best Kegel exercise. And then you have her do a series of repetitions followed by a sustained hold and then the pulse. We say the power's in the pulse. The pulse is when we're making a small range of motion around the point of peak passive engagement, reflected here during the hold, while adding a strong voluntary pelvic floor contraction and percussive breathing. Percussive breathing is exhaling hard and quick with your mouth open and making a noise like that's a percussive breath, right? And it really gets the transversus abdominis recruited. And so you're trying to optimize the reflex overflow to the pelvic floor, creating more motor unit recruitment. This is all done with surface EMG electrodes that provide an amplitude proportionate to the number of motor units, muscle cells that are firing at any given time, right? And so I'm gonna go ahead and play this clip for you guys, and then I'll narrate it a little bit. So you see this little dotted line that's moving on the screen left to right? That's where she is in the video. That's what's going on EMG-wise at the given point in the video. And I wish I'd get out of the way here a little bit. This is in Japan a while back. I forget what city, maybe it was Korea, I don't remember exactly. But and so now she did her Kegel, she's getting ready to do, and she's bridging, okay? So she's coming up to the top of the bridge, the balls between her knees providing progressive resistance to the lower extremity adductors. We're cueing her glutes. We're talking to her about what's coming next. And now we're gonna say, you're doing that movement, great, go ahead, come to a hold. Now, she's holding the movement at the point of peak passive engagement. She's not doing any voluntary pelvic floor work yet, but it's already stronger than her isolated Kegel. Now, we've coached her already, so we're getting ready to pulse, and you're gonna breathe, and you're gonna make a small range of motion, voluntary Kegel and percussive breathing, and then this is what she's actually capable of during that pelvic floor contract during that movement. And you can see just how much better that is in terms of motor unit recruitment than her isolated Kegel exercise. Now, there's some, so that's kind of the basics of how VESI works. Here's another, that's not the one I wanted to show you. Let's see here. Right, here's another example. Japanese actually taught me this. This is kind of like bridging in a prone position. And so these exercises can be done even if you can't get out of bed. We've rehabbed people in wheelchairs with no legs. You can adapt and modify these movements. And I'll tell you something, Heather is an absolute genius at this. And I'm gonna stop talking in just a second and let Heather go through a couple of the movements, but I do wanna just explain this clip. And so what they're having this client do is while a prone, do her Kegel, which we always do the clip the same way, there's her isolated Kegel, and now she's gonna do a pelvic curl into the floor, right? She's just using the floor as a point of resistance to curl her pelvis and not trying to add a voluntary pelvic floor contraction at all, but just getting the movement down. And then here's this portion here is going to be her sustained hold. And so you can see that even without trying to do a voluntary pelvic floor contraction, she's achieving about the same level of EMG activity for the pelvic floor by just doing the movement. The passive recruitment of the pelvic curl against the floor, right? Holding, now she's gonna pulse the movement, add that voluntary contraction while doing the movement, and you can see she's achieving 200–300% greater pelvic floor activity per contraction. And that roughly translates to 200 to 300% greater motor unit recruitment per contraction. And that means the program's going to be more efficient. Is going to be more efficient. And so, you know, it looks like it's about, we have about 10 minutes left, and we're cautioned not to go over. Heather, do you feel like you could go through one or two movements just to kind of show how the movement's done? And it would be basically the same way we do it if we were in the lab. And then if we have a couple minutes left at the end, I could answer questions. I will give you guys my personal email address. If you're interested in attending our certification in July, you'll find it very, very interesting. We'll demo the VESI lab with a live subject. And you can pick out experiments you want to do to see if what you're currently doing is good for pelvic floor or how you might make it better. And so my email address is pf171@live.com, livictor.e.com. Or you can contact us at the office, 775-284-3482, 775-284-3482, or pf171@live.com. All right, so I hope that was interesting for you guys. Let's see, I am going to stop sharing.
And then Dr. Crawford, you had a question as to whether this would be good for women in their 50s or 60s.
Yes, just briefly, I'll tell you about Betty. Betty came to me, she was 83 years old. She was an administrative employee at the University of Nevada. And on the weekends, the city paid her to drive a Scion around and report people for civic violations. She was a real pain in the ass, but she was upset that she couldn't work anymore because of her bladder control problem. And in 6 weeks, she was 50% better. In 12 weeks, she was back in her Scion, back at work and thrilled. It's ideal to begin as close to the time of an injury as possible, but it's not essential. You can still recover the pelvic floor in your 8th decade of life, and probably, depending on your health, even beyond that. So yeah, this is something that people of all ages can take advantage of, and the movements are all modifiable, so it doesn't as I said, we've had people with major disabilities still do this.
And Dr. Crawford, I'm just going to give a little bit of my personal testimony, if you're okay with that, before we get into the exercises.
Okay.
I found Dr. Crawford about 10 years ago, after I had had pelvic floor nerve damage during the birth of my son. I was incontinent after that. I had lost sexual functioning over time, even though I had been doing traditional Kegels. It was not helping. So over time, I eventually developed prolapse, and actually all forms of prolapse, to the part where my upper vaginal vault was starting to fall. And I was desperate. I was completely desperate. I found Dr. Crawford was doing a workshop in Chicago. And I'm like, I have no idea what this plyometric pelvic floor thing is, but I haven't heard of it and I haven't tried it, and I'll do anything to try to avoid surgery. So I have completely been able to avoid surgery and have not had any surgery at all. I have completely regained continence of bowel and bladder both. I can even jump on a trampoline or a rebounder when I have to go to the bathroom and not pee my pants. And then I've also regained sexual functioning. So you're never, in my mind, too far gone unless you're the woman in the pictures that Dr. Crawford showed earlier. But it's never too late to work on this. And my son was 5 years old when I found Dr. Crawford. So I'd already been enduring all of this for 5 years. And I'm in my late 40s now, and I'm super excited that as I'm aging, I feel stronger than I ever have. So, and I attribute that all to Dr. Crawford and the Pilates program, which is why I will always help him whenever he asks, because I just think he's an amazing person. So anyway, I'm going to show you guys 1 or 2 exercises.
Maybe just one, so
okay.
I can try and answer some of the questions that are coming through. Yeah. And then, but if I don't get to all the questions, just call me or email me. I promise that I will answer every question in due course. But you go ahead.
And Bruce, go ahead and put your email in the chat box too, so people can have that.
Oh, chat.
Okay, go ahead.
All right, one of the exercises that is a very high yield exercise, meaning when people go through the VESI, this is one of the exercises that tends to be one of their top 2 or 3. And this is across the board. I know Dr. Crawford and I both see males at our clinics and our studios as well. So whether it's a man or a woman that's coming in to work on their pelvic floor, this is one of the exercises that tends to be a really popular one that people get a lot of benefit from. I'm in a kneeling position. I'll just turn so you can see me from the back. My feet are touching. I'll come back to the front. On this exercise, we go into a hip hinge and we sit back onto our heels. Now as we come up into hip extension, I'm trying to pull my legs in, almost like I'm pretending like I'm crinkling the mat up in between. I'm contracting all my core recruiters, my glutes, inner thighs, my pelvic floor, and my abs. I relax as I go back into my hip hinge, and then I contract as I come up. So we inhale on the way back, and we exhale on the way up. And you can modify this, and if you choose to do the training program, we go through multiple modifications for all 10. There's also ways to progress this and make it more challenging. So after we have people do several movements just to get the motion down, we do the isometric hold. So we're preloading before we go into that plyometric quick motion. And this is when we're really trying to incorporate the breathing. I take my inhale. As I exhale, I do my pelvic thrust. I inhale, release, exhale, pelvic thrust. I'm going to turn to the side so you can see me, and I'm going to do it a little quicker. And as I'm thrusting, that's when I'm trying to get more pelvic floor activation. So even though the pelvic floor naturally works during that pelvic thrust, we want to exploit that more by intentionally trying to get a deeper contraction when we're in that peak plyometric phase, so we get more force production and more fast twitch muscle fiber activation. So all the exercises have a motion, an isometric hold, and then we go into the plyometric component. And they're very functional. We have kneeling ones, we have sideline, we have supine exercises. So it's designed to help translate into other movements that you would do in everyday life as well. Is that good, Dr. Crawford?
That was awesome. That was awesome. Thank you so much, Heather. Listen, if you guys ever get an opportunity to work in any workshop with Heather, jump on it. She is really just a marvelous talent and a kind person. So thank you for that. You know, I just added to the chat room an article published through the University of Toronto looking at the effects of Pilates in the incontinent male after prostatectomy. It was a randomized controlled trial that showed that Pilates was 50% better than traditional go home and do your Kegels. And so you guys feel free to download that from the chat and take a look at it. And you don't have to be a certified Pilates instructor to take the course. Look, this course is real theory heavy because the movements just aren't that complicated, right? Understanding why these movements work is what makes you an expert and useful to people. So it's not just enough to know that they work. You could take my word for that, but you need to know the backstory. You need to know why they work. And so that is what we accomplish. We generally have a lot of fun at the same time. So,
Dr. Crawford, there was a question from Penny as to whether these, if any of these work for people that are unable to get up and down off the floor. And I will tell you, yes, that was one of the things. We have a whole supplemental manual that you'll get when you go through the training program. And a lot of the upright exercises I ended up creating later on when I started implementing this at my studio, because I had people coming back and I would inquire as to, you know, are you still doing the exercises? And I had one woman in particular that said, no. And I said, okay, what is the limiting factor? She said, I hate being on the floor. She was totally capable of getting up and down off the floor. She just didn't like to be on the floor. So I went through and did a whole series of exercises where we incorporate the Pilates work in an upright position. So yes, you can definitely do this with people that are unable to get up and down off the floor, whether it's a physiological reason or they just don't like it.
For sure. What else? Anyone can unmute, ask a quick question. We have a couple of minutes left.
Well, I got a question for you, and this is kind of in the kind of the business side of things, really. You know, for individuals you're looking to help people. In your experience with the fitness trainers, how have they been implementing this into their program? You know, is it something that they just do one-on-one in groups? How do you maybe
That's a great question.
How do you get people to refer to it if you're just a fit pro, you know?
Right. So, you know, some people do put on regular sort of pelvic floor seminars in their studios, right? And others will, and then they will, from those maybe 1 or 2 hour seminar, they'll get people signed up for a 6-week pelvic floor program. And the program comes with a whole kit of ball, book, DVD, educational guide, program guide, access to vesilab.com, where students have their own private page and you can send them assignments and worksheets. And, you know, that's a $200 value. in itself. We sell those. I have a Zoom call in a day or two with a woman in South Korea that I sent a kit to that we're working on her program remotely. But usually they'll come into the studio and work with you maybe 4 or 5 times over the course of 6 weeks to achieve the program. And so you learn how to do that when you take the course. And we charge $500 for a 6-week program. If we were billing insurance, we'd be reimbursed $1,500 for that same program, but we don't take insurance and we make people pay cash. And so it's more accessible that way. But the value is tremendous if you think about the value of avoiding an operation or having to fill a prescription for an anticholinergic medication that gives you dry mouth and constipation and other things. And so from a business standpoint, some people will teach it in group classes. I think Heather has the group class she does, and we have group Pilates movement classes, multiple times a week here at Vessi Lab Functional Fitness. But in terms of the pelvic floor program, we mostly do it one-on-one.
And one of the things I did at my studio after I went through Dr. Crawford's training program, because no one was doing it in my area, is I reached out to some of the local pelvic floor physical therapists and OBGYNs, and I offered to do kind of a complimentary session just so that they could come in and experience it firsthand. And that led to a significant number of referrals that continue to reoccur. Even now, I get a lot of doctor and PT referrals. So I think reaching out and trying to collaborate with the local medical community, letting them know that you're not trying to take away from what they're doing, you're trying to enhance that and help patients. It's worked really well for me. And that's one of the things that we talk about too in the certification program is implementation techniques, but that was something that really benefited me.
Well, thank you, Dr. Crawford and Heather. We appreciate this great information. Really was awesome.
Thank you.
And something that you just don't, in especially the fitness world, we might hear about it a little bit, pelvic floor stuff kind of floats around here and there, but to really kind of hear from the inside from a urogynecologist that's working with, these major issues that women are having that no one's talking about, really, and it's kind of hidden, I guess, is just amazing. So thank you for sharing your skills with us, and hopefully everybody will check out your certification program.
Oh, I hope so too. Thanks, everybody. Thanks for the engagement in the chat.